In our last video, we discussed how glucocorticoids work and reviewed both their good effects and many of their potential negative side effects. In rheumatology, we cannot use glucocorticoids at high doses for prolonged periods of time because of their unacceptable number of side effects. Beginning as early as the 1950s, just after the dawn of the use of glucocorticoids for therapeutic purposes, 3 principles for how to use glucocorticoids wisely were developed from clinical trials in that era. We still apply these principles in clinical practice today. Let's review them. The first principle is to use glucocorticoids in the right patient. Some inflammatory diseases can lead rapidly to organ-threatening inflammation. In those diseases, the physician should use a strong tool as the first-line therapy, with the goal of suppressing inflammation quickly and preserving organ function. IgG4-related disease is often one of these diseases. In fact, by the time the disease is diagnosed, IgG4-related disease has usually been going on for months or even years, and significant organ damage may have already occurred. In such cases, rapid control of the inflammation is important to prevent further damage. Further treatment options may someday allow first-line treatment combinations that do not include glucocorticoids, but for the moment, glucocorticoids are nearly always part of the initial treatment regimen nearly everywhere in the world. The second principle is to use the right dose for the right duration of time. For me, the right dose is the lowest amount of drug that achieves our treatment goal, complete suppression of the inflammation. The right duration is the shortest period that allows me to withdraw treatment while preserving its effectiveness for at least a while, because the treatment course has been successful in stifling inflammation, hopefully for a long time. Glucocorticoids cannot be stopped abruptly. Rather, they must be tapered in order to prevent symptoms of glucocorticoid withdrawal. In a previous video, we discussed that the body produces its own glucocorticoids naturally. These hormones are essential for normal functioning of the human body. One of these glucocorticoids, produced in small glands overlying each kidney, known as the adrenal glands, is known as cortisol. When large doses of glucocorticoids are given to treat an inflammatory disease, the production of cortisol by the adrenal glands is suppressed. As the therapeutic glucocorticoids are being discontinued, it takes some period of time before the adrenal glands wake up again and resume their normal production of cortisol. Because of the time required for adrenal gland recovery, doctors prescribe tapers for patients on glucocorticoids. The duration of the taper, during which the dose of the medication is reduced steadily over prescribed intervals, varies according to the dose of glucocorticoid the patient has been on and the length of time the patient has been treated. In my IgG4-related disease patients, a starting dose of 40 milligrams a day for up to 4 weeks is usually enough to control inflammation quickly. I usually then taper the prednisone off completely within the next 2 months, reducing the dose each week. I find this regimen is optimal for achieving flare control while being short enough to minimize side effects. It is important to note, however, that there are as many ways of using glucocorticoids as there are doctors. In many parts of the world, it is common to taper the patient's prednisone to 5 or 10 milligrams of prednisone a day, and then to maintain that dose for a long time, often several years. The third principle of glucocorticoid use was to choose the right level of risk. In some patients, the risk of using glucocorticoids is just too high regardless of the benefit. For example, the risk of treating with glucocorticoids is not warranted in a patient who already has uncontrolled diabetes, a patient who has already suffered from osteoporotic fractures, or a patient who has experienced major psychiatric symptoms such as depression or mania. in the past. In such cases, we would use another treatment or attempt to control their risk factors first, only using glucocorticoids if there were absolutely no other alternative. So, in summary, the three governing principles were to use glucocorticoids in the right patient, at the right dose and duration, and at the right level of risk. In this mini-series, we focused on glucocorticoids, a very important class of drugs for the treatment of inflammatory diseases. Glucocorticoids are among the most commonly prescribed drugs in the world, and it is estimated that at least 50 million individuals across the world are on chronic treatment with prednisone or another such glucocorticoid for one condition or another. It is vital that you become an active participant in your medical care. I find that those patients who are partners with their care team have the best outcomes. To participate, you must learn about your disease and its treatments. In this series, we looked at the history of glucocorticoids, how they work, and what side effects they have. I encourage you to talk to your doctor and care team to make sure you understand thoroughly whatever treatment regimen is prescribed for you. Thank you for watching, and I hope to talk to you again soon.